take a second and just chat about myself. This will be recorded and posted later. Hi, thanks for joining. So, my name is Dr. Camille Kraus, and I am a naturopathic doctor here in Kitchener-Waterloo. I live here. I've lived here most of my life, and I now work out of one of the fertility clinics here in town, along with my other Conceive health colleagues, and that is super rare, right? To have a naturopathic doctor working with the conventional medical system. So I'm excited and energized by that constantly. So I want to tell you, what my role is. So a patient will have their kind of full workup with the fertility clinic. And then I have my own kind of investigations that I like to do as well. It's additional blood work, and we get the full sense of that patient's health history and where that might be impacting their fertility. And then we put together a game plan that might involve diet, lifestyle changes, and often supplementation as well. So what we're going to talk about today is the insulin component of that. So if a patient has had their full workup with a clinic and they may or may not be told that they have PCOS, but basically they may or may not be ovulating or not ovulating consistently every month or every cycle, then that's where we do a little bit of a further workup to see if insulin is what is causing that, because it is a big culprit. And you can be investigating this even if you aren't working with a fertility clinic. Maybe you've just started trying to conceive and you're still realizing that your cycles are long and you may not be ovulating every single cycle. Then this is what I would want to do as well. This is the kind of testing that I would want to do. So just to back up even one more step here, I would say in our clinic at least, probably 50 to 70% of patients at our fertility clinic don't ovulate. And that's actually, we can get you to ovulate with medications. So that part is okay. But there are some naturopathic considerations for improving egg quality and reducing the risk of miscarriage when we do improve that person's baseline health status. Even if we can get them to ovulate with meds, we will still want to improve some of those health parameters at the baseline. And so now if that many patients that come to a fertility clinic aren't ovulating, we can get them to ovulate with meds. Some 80% of those cases are going to have PCOS. And the majority of PCOS cases, again, it's like 80% of people who have PCOS are going to have their insulin affected. So I love this topic because it really kind of addresses so many of our fertility patients, whether you're with a clinic or you're just starting to try. So let me back up a step and tell you what insulin actually is, because I like to make sure we're kind of all on the same page. So when we eat something, when we eat a carbohydrate, and it doesn't matter for these purposes whether it's a donut or a whole wheat piece of bread, right? Like we know there's a difference, and I'll get to that difference. But at the end of the day, our body is going to break those carbohydrates down into sugar in our system. That sugar is going to enter our bloodstream, and our blood sugar is going to go up. And then our body is going to release insulin to open up the cells and pull that sugar into the cells so that the cells can use it as fuel. Good, that's what we want to happen. Then the blood sugar goes down. And now what happens if we're kind of eating either more carbs than our body kind of has room for in those cells? Then our cells start to say, I don't have any room. I'm not listening to this insulin signal. So our body's going to keep making insulin to try and get the blood sugar to come down. And all of a sudden we end up with higher levels of insulin in our bloodstream. Now that insulin is going to cause problems, and I'll get to that. But basically what we see just too much glucose in the system. Our cells are full, and it's kind of an analogy of there's a lot of background noise in the room, so we keep turning up the volume dial to try and like actually hear the radio, right? And that's what insulin is. It's just getting louder and louder to try and get the body to listen. That extra insulin hanging around is going to do several things. The first is it's going to tell the body to store fuel for later. It's going to say, well, okay, the cells don't want this glucose, so let's turn it into fat and kind of pack it away for later. So that's going to be a problem. If anybody has ever tried to lose weight and been frustrated that they can't, then that high fasting insulin has to come down. So that's step one. That high fasting insulin is also going to be causing oxidative stress at the level of the ovaries and affecting egg quality. So there is actually some research that high fasting insulin and insulin resistance is going to then have an impact even at the level of IVF, for example. And one thing I really like to talk with my patients about is that the BMI is not necessarily our end goal. So let me step back a moment and say, I mentioned I do an extra bit of workup with my patients in addition to what a fertility clinic or a conventional doctor might do. And it's really easy to test fasting insulin. So I test fasting insulin and fasting glucose, and we can use those numbers to get something called a HOMA-IR, homeostatic model of assessment for insulin resistance. It's a mouthful, but that's what you're going to see some of the research on, either HOMA-IR or insulin resistance, when you're kind of looking at this, like what the issues with insulin and fertility are. So we can actually just measure somebody's fasting insulin, right? That's really easy to do. And it's going to give me a sense of whether that person is kind of at like no insulin resistance, mild to moderate, more, maybe we'll say mild, moderate, and then severe, right? And I see patients at kind of every value, and it does not perfectly correspond to BMI. So I like to make that clear that for, at least for our purposes, when we're talking about egg quality and fertility, we really are focusing on that insulin resistance piece more so than the number on the scale, because the metabolic conditions that high insulin creates are going to affect you more than just the weight of your body itself, okay? So I really like to make that clear that, if we reduce your fasting insulin and you lose some weight, then that's maybe a nice side effect if that's something that is a goal for you. But it's not an end goal for me. It's not an end goal for your fertility. And it might be a goal if you're working with an IVF clinic and you want to do an egg retrieval. An egg retrieval is minor surgery. And so they are going to, have a certain BMI cutoff to make sure that procedure is safe. That's really kind of the only place that weight is going to play a role, because the work that we're doing together is going to support, your antioxidant status, and your hormones, and how that whole metabolic milieu is going to affect egg quality and fertility. Okay. Makes sense for kind of how insulin even works in the body. So part of our goal then is to kind of reduce that glucose load in the first place, how much carb somebody might eat. And so one of the kind of questions that came up through our Instagram page yesterday was, okay, is there like a target number for carbohydrates and what kind? The goal really is to kind of minimize the blood sugar spikes, and every time we get a blood sugar spike, we're going to get that insulin release. And so if we kind of smooth that out and make it kind of a slow, steady blood sugar with lots of protein, fat, and fiber, then we're going to minimize the impact on our insulin and on our blood sugar. So that's kind of step one. To kind of just make that slow burning fuel. So this is where I go back and say there is a big difference between a sweet potato or a piece of whole wheat bread and a donut. And we're still going to be wanting to choose more towards the whole foods, fruits and vegetables than the processed foods and baked goods. So those are still going to be better decisions overall for balancing your blood sugar and modulating your insulin as well. And then the other thing, so in terms of an actual number goal, this really is going to depend on the case and kind of the goals and the timeline too. Timeline's going to matter here. Do we have 1 month to get things where we want, or do we have 6 months, right? So that's going to matter. But I would say somewhere in the neighborhood of 150 grams of carb per day is pretty reasonable. It's kind of that nice balance between, we'll call it kind of moderate carb. It's not true low carb. It's definitely not keto. I'm not a big fan of keto for fertility, and we can talk about that. But it is a nice moderate number. The typical standard American diet has something more like 300 grams of carb per day. So we're reducing that quite a bit. Technically 150 grams of carb per day is considered low carb, but then keto, for example, is like 30 grams of carb. So we're somewhere in that mid-range. With 25 to 30 grams of fiber, because the fiber is going to be super key to keeping you full and keeping your blood sugar more level. So those are the big things I want you to know, like kind of the bigger overarching concepts. And I can get into some of the more nitty-gritty here. So feel free to be posting questions if you have them. I will answer them at the end if we can get to that. So some of the things that I want you to know about that high fasting insulin, I kind of touched on it, that it is going to affect egg quality and possibly miscarriage risk. So one of the stats is that a patient with PCOS, and now I'm going to clarify because this paper didn't clarify, but I'm 90% sure they mean PCOS that has insulin resistance as part of the PCOS picture, has a 3 times higher risk of miscarriage in first trimester. So now our goal is not just to get you pregnant, we want you to bring home that baby. So everybody is going to want to reduce that miscarriage risk, and modulating insulin is going to be part of that, the way that we do that. Then, let's see, what else do I want to tell you here? Good. And then the other piece is just when you actually are pregnant, then if we can kind of correct this insulin piece, then we're going to reduce your risk for gestational diabetes and what that means for your health and the baby's health, right? So I think that's a really nice goal as well. We don't just want you to bring home that baby, we want it to be a super baby and as healthy as possible, and we want you to be as healthy through your pregnancy and delivery as possible as well. So now I've kind of said that PCOS is usually largely insulin related. And so I want to break that down a little bit more, because there are about 4 different types of PCOS. So if you've been told that you have PCOS, you're going to want to know which kind, because the approach to treating it is going to be different. So that's part of the additional workup that I do. Typically, a patient is going to have an ultrasound, and that report will literally say PCO appearance of the ovaries, polycystic appearance, so they can count all those little follicles, and if there's like more than like 15 or 16, sometimes it's like 30 per ovary, then they're just going to say, looks like these ovaries have that kind of PCO look. And then we want to figure out what kind it is. So we have insulin related PCO, we have adrenal related PCO, we have post birth control related PCO, and then we have beta carotene. Well, that's a kind of a niche one that I won't get into today, because that's a whole other topic. So we'll come back to the insulin one. 80% of PCOS cases are insulin related, right? And so that's where we kind of focus on it. But some of this stuff is just easy blood work, right? What's going on with, we can test the fasting insulin, the fasting glucose. I test DHEA, sometimes cortisol, to tell us if it's kind of more adrenal based. You can test beta carotene, and if you just came off the pill, then that's going to answer that question. So we want to know what kind of PCO we're working with, because we get into this whole other category of lean PCO, which may or may not be insulin driven as well. So I'll share just a little bit of kind of a personal background. Is I tested my own insulin because I was curious, and I have a BMI of, I don't know, I haven't measured it in a while. We'll say like 22, right? So I fall into more of the lean body type. And my fasting insulin was high. It was a 70, which is not outside of range. But when I said mild, moderate, high, then I would fall into that kind of moderate category. So the way that carbs affect me is showing up on my blood work. So now my blood sugar is probably more doing this. I have to work really hard on my blood sugar to not kind of have those crashes. And I do feel those crashes. So I'm more prone to getting hangry, which is a fun word that I'm sure some of you can relate to. And basically it just means that my body is not managing that blood sugar very well. My cells are a little bit insulin resistant, so my body keeps having to try and use insulin to get the cells to listen. And so I kind of really have to moderate what I eat, and I can feel it. Like once you start noticing these things, and once you know kind of the connections between what you do and how your body feels, and you start to notice it, that's when you can start to really change it. So if I ate like a baked good right now, I would have a massive crash. I wouldn't feel too good. And so I eat in a way that's going to make me feel good. So our lean PCO or our kind of more mild insulin resistant cases, or even our, I shouldn't just say lean PCO, even our higher BMI but moderate insulin resistance patients, we still need to make sure that we're addressing fat, fiber, and protein. Make sense? I miss having live presentations when I could just ask the audience, are you with me? And move on from there. Okay, we got a good question that just came in. Can you have two different types of PCOS? Ooh, I've never thought about that. I don't know that you'd be able to tell what's what. Like you could have insulin resistance and also some adrenal stress. So yes, and you could have insulin resistance and high beta carotene. Yeah, you could have just come off the pill. So probably, but do we know, could we kind of like formally say, oh, it's just different issues on a checklist that we're gonna deal with. I have a couple other questions here that I can start getting through. Does a diet truly affect getting pregnant? Absolutely. So what you're going to see is that the primary thing you're going to see in the research is that diet's going to affect your kind of antioxidant status, right? And a big part of egg quality is going to come back to oxidative stress. And so if we want to counterbalance any oxidative stress that might be harming our egg quality, we need to eat antioxidants. And so that's what's going to help support egg quality. And you're going to get that from your fruits and vegetables. So that's part of our baseline, is to say, okay, we can put you on all these fancy supplements that support egg quality, and we're going to, but I also want you to be getting this stuff from your food, because those phytonutrients in fruits and veggies, we can't extract them all, and we just can't recombine them better than nature can. So you still need to eat your fruits and veggies. That's going to help improve egg quality through those antioxidants. And then there is enough research, on insulin resistance. So if somebody is eating kind of that higher processed food, higher carb kind of a diet, and their insulin is really high, then yes, absolutely. There's enough research to say that is going to affect their fertility. Is going dairy-free good for fertility? Okay, that's a really good question, and it depends on the person. So let's talk about dairy for a second, because dairy actually is shown to have more of an insulinogenic effect. And so certain types of dairy are going to spike your insulin a little bit more. And let me break that down. So our higher fat dairy is going to be better. It's going to have less of an impact on your insulin. So our like full fat yogurt, full fat milk, cheese, cottage cheese, those kinds of sources are going to be better for you for not spiking your blood sugar. And then if we take all the fat out, so you're doing like the 0%, then there's nothing to buffer it, and it is going to actually spike your blood sugar. So depends on the case. I'm not going to blanket remove that for every situation, but yes, there have been times when I have said, okay, we need to at least reduce it. You know, if you're drinking straight milk, especially if it's skim milk, might not be working in our favor. What foods should you avoid with insulin resistance PCOS? And I love the way you phrased that you actually recognize that there's an insulin resistance type of PCOS. And foods to avoid is really just our high carb foods. You know, so one of the other questions actually is gluten terrible for fertility? Like, no, none of this stuff is blanket bad for us, right? Like, there's no cut and dry that you should just be off of it. But one of the ways that I find going gluten-free helps is you don't just quickly grab the bagel or stop by and pick up a muffin from Tim Hortons. It does cut out some of those like fast carbs. Like, I've been gluten-free for 10 years and I have to be strategic about what I eat and when, and I have to pack my food, and I guarantee you that means I'm eating more whole food just because I can't like swing by somewhere and pick up food when I'm hungry. Okay, so that's the only way that I find it beneficial here. So no, you shouldn't necessarily avoid gluten if you have insulin resistance PCOS, but some of those fast carb and baked goods and things would be a good idea to avoid, and lean more towards whole foods, those fruits, vegetables, whole grains, and food you make at home. Good. Is intermittent fasting a good idea? Okay, let me come back to that one, and I want to see some of the newer questions here. Can polycystic ovaries go away? You can definitely, yes. I have seen on subsequent ultrasounds, I have seen kind of the numbers of follicles reduce, so that what we're seeing is that patient is like actually ovulating follicles, and their body isn't just kind of making a bunch of immature ones each month that never go anywhere. So I have seen those follicle numbers reduce. But all of this is like genetic predisposition. And so if you manage it, then yeah, you can kind of get those numbers under control, get those hormones, that metabolic state we talked about, you can get it all under control. But you always have that genetic predisposition. Okay, so you could always kind of go back to having that condition and all of the implications if you don't continually work to address it. Does Clomid work to improve ovulation in irregular cycles? Yeah, so Clomid's going to make you ovulate, right? So it's going to kind of put you on a timeline and make you ovulate. And so Clomid's going to work. I see most docs in Canada are now using letrozole, which works by the same method. You take it for usually 5 days in your follicular phase, cycle day 3 to 8 or 9 usually, and then you stop, and then usually they're tracking, make sure you ovulate, or you're using at-home LH tests, and that should then make your cycle more regular, because then you could expect a period or a pregnancy 14 days after you ovulate, plus minus a couple days, because bodies aren't machines. Someone I know from the US said their fertility doc told her to avoid carbs while they were taking stims prior to egg retrieval and after. Did they mean refined carbs? Why would this be suggested? Yeah, it sounds like a blanket statement, because we don't want to confuse people. Like, what is a refined carb? Is whole wheat bread a refined carb? Are sweet potatoes cut up into something? Like, it could get a little bit sticky for patients, so they might have just said blanket statement, all carbs, just to keep it simple. I don't know why they would have said just during stims and after. I think people would benefit more from a bit of a longer term strategy. What about someone who's plant-based? Does that have any impact while doing fertility treatments? So just to answer that in context of what we're talking about here with insulin and fertility, the biggest thing that I would say is that people who eat plant-based tend to eat more carbs because all of your sources of protein do come with more carbohydrates generally. Like legumes are kind of the biggest example. They, like I think it's about a half cup of beans or lentils is going to have about 10 grams of protein, but maybe like 30 grams of carb, like a pretty significant amount of carb in there too. Whereas any meat source, eggs, fish, meat, is going to have no carb whatsoever. Dairy is different, we talked about that, but our eggs and meats, no carbs, all protein and fat. So yes, they are going to have generally, I'm kind of broadly painting everyone with a brush, but I do see people who eat plant-based just generally eat more carbs. So that is something that I would consider if we were kind of working on a plan together. I would probably be implementing more protein powders where they can get that protein without the additional carbohydrate attached, and make sure that they are getting enough protein, fat, and fiber just to balance out any blood sugar. But really, the testing is going to tell us, right? Somebody could be eating plant-based and have no issues with their fasting insulin. So the blood work is going to be the thing that tells us and helps to guide treatment. Great questions. Yeah, I love them. Keep them coming. I have one interesting study that I pulled up just to kind of make sure I was addressing the question. We had a question come through yesterday that said, can sugar affect egg quality or embryo quality and IVF success? So the answer is yes, but it's not just sugar, right? Like let's get it out of our heads that let me correct one myth that something like honey or agave is a better sugar than like refined white sugar. They're all sugar. Like your body is going to take that honey and turn it right into glucose, and it's going to hit the bloodstream the same as refined sugar. It just might have more minerals attached to it, right? So it'll still be a little bit different in your body, but for what we're talking about, same glycemic impact. So not just sugar. All carbs, like I said at the start, whether it's a sweet potato or a donut, your body's gonna just break that down into its glucose, right? So the study that I pulled that was specifically about IVF was 50,000 IVF cycles that they analyzed. Of those cycles, 10% of those patients used metformin during their IVF cycle. The indications of why they were on metformin included anything from PCOS patients who had recurrent pregnancy loss, was 67% of that sample, poor egg quality in prior cycles, 61% of the sample, high serum insulin levels, 56% of that sample, and then a little bit lower kind of quantities here were our PCOS with obesity or PCOS with anovulation or PCOS with kind of multiple categories that I just named. Half of those patients, so were treated with metformin for 3 months prior to starting IVF, and they used kind of the standard dosing of metformin. And they continued taking the metformin up until either their positive beta HCG, or up to 12 weeks of pregnancy. 70% of those cycles, of those IVF cycles that were medicated with metformin, reported increased pregnancy rates and decreased miscarriage rates due to the use of metformin. Those are pretty powerful numbers there, right? And these are the kind of numbers in the data that we want to see that can kind of leave us saying, we're on to something, right? I don't want a study of 50 people. Unfortunately, some of our studies are still small studies, but I want to see these like thousands of patient trials or real examples, real cases. And then to see 70% to have increased pregnancy rates and decreased miscarriage rates is huge. So I was really kind of excited to see that. So I would argue that you're going to have that same benefit to improving egg quality and reducing miscarriage risk at any point in your trying to conceive process. You don't have to be doing IVF to still be benefiting from the possible impact that this could have. All right, another question here. How long after coming off the birth control pill can that impact PCOS? I actually haven't looked at that in a really long time. I think the data says around 6 months, but maybe one of my colleagues can correct me after the fact that there's a potential impact. Now, the birth control pill is not all bad, right? Everybody thinks you have to do like this like washout period before you get pregnant. It just doesn't work that way. Birth control pills can actually reduce androgen levels, which is our testosterones, in patients with PCOS. And so some patients actually can conceive easier coming off of the pill if they have that kind of predisposition towards PCOS. Some will and some won't, okay? So that's not everybody, but that's why it might seem confusing that do we need to do a washout or a detox or whatever after the pill? And I would say definitely not. Your chances might actually be better right afterwards. How long does it take for inositol to regulate blood sugar if following an eating plan to regulate insulin resistance? Okay, yes, so I'm glad you asked because I also meant to talk about how, because we have this like mild, moderate, and severe categorization of insulin resistance, then I'm also going to say that I have kind of a simple plan, and then it gets more and more layered, right, of how much work we need to do to regulate that high fasting insulin. And so somebody with, mild to moderate insulin resistance, we can just use diet, balance you out a little bit that way. The next layer would be supplementation. So there's kind of 3-4 main supplements that we would consider using. The top is inositol. The second would be berberine, and then we get into NAC, vitamin D, omega-3, kind of those things that are still super beneficial, but I'm not going to put somebody on all 4 of those things, okay? I want to make that clear. I'm going to pick and choose based on the person's case. So how long can inositol take to have an impact? I've seen it have an impact very quickly. I don't retest a patient's insulin. I retest once a month, so every 4 weeks, to see that those numbers are coming in line. But I anticipate, between their initial test here and the 4 weeks from there, that it's kind of doing this. So you are going to see a difference probably week over week. Then another question here. Can you do a live Q&A regarding adrenal PCOS? Yes, I think that would be so helpful. There's not great data on it, but we can answer kind of what we can here. I feel like stress is one of the more difficult things to control while TTC. I don't want you to feel like your stress that you are causing infertility in some way, or that it's what's preventing you from getting pregnant. Let me be super clear on that, and I'm clear with all of my patients. You being stressed about trying to conceive is not what's causing you to not be able to conceive. It's way more complicated than that. It's going to come back to some genetic predispositions as well. So yes, we should definitely talk about that topic in more detail, just to make sure that patients do understand that. And and kind of clear that whole thing up, because it's confusing, and I don't want you to feel like this is just, you just need to stress less. It doesn't quite work that way. Yeah. What is your take on myo-inositol? So, I mean, yeah, you're gonna see some studies saying it has to be myo and not D-chiro and all of that. They kind of interconvert, so I'm not as picky as I once was. We kind of put people on, it's like a mix. It's mostly myo, but there's a little bit of the D-chiro in there. And that's mostly what you're gonna see on the market, right? So it's going to be kind of the right form. Don't overthink that. Is it good for egg quality? Yeah, just because of all the reasons we just said, that the insulin itself is not great. High insulin is not great for egg quality. And so if we use the inositol to correct the high insulin, then yes, we will improve egg quality by doing that. Can you have regular insulin levels on blood work with PCO and have some level of insulin resistance? Not really. Your insulin doesn't really lie. It's gonna tell us. It's pretty much gonna tell us what's going on there. So if you have regular insulin levels and you've been told that you have a PCO appearance of your ovaries, say on an ultrasound, then it's probably coming from somewhere else. Your blood sugar may still be doing this. You may not be insulin resistant, but you might be on the blood sugar roller coaster. And so it could still be worth balancing out your blood sugar and managing your carbs with some fat, fiber, and protein. I'm gonna make that into a ditty one day. Fat, fiber, and protein. But yeah, the blood work is gonna kind of tell us and confirm that. Can NAC and inositol cause your blood sugar to drop too much? Okay, so patients who maybe are more prone to the blood sugar roller coaster and are more likely to get hangry if they skip meals or don't eat, then they might feel a little bit weird with inositol, because it might kind of it's not going to drop your blood sugar, but it is going to affect kind of that blood sugar balance. So you might notice that, right? I haven't really seen it in my patients because we're just, I don't know, the dose seems to still be okay. The dose is around 4 grams, right? So at higher doses, maybe it would, but I've seen it usually be okay. Silly questions. Are dates bad? I usually eat 1 to 3 dates per day when I'm craving something sweet. So let me be clear. Great question. Thank you for asking it. But of all the things you could eat or do when you have a sugar craving, I think dates are okay. They're a lovely way to get a little bit of that carbohydrate that you're craving, okay? I don't want to make it seem like all carbs are bad. They're not. We just have to know what numbers we're working with and what you test out as and what your goals are. So you could be, doing a lot worse. I'm thinking like all the Cadbury cream eggs that are on the market right now. That's going to be just the same glucose hit without any of the benefit of vitamins and minerals. So you're at least getting a little bit of that in the dates. So I'm not going to say they're good or bad. I'm going to say get tested and find out what your body's telling us. And I'm going to be wrapping up soon here. So thank you so much for all of your questions. Thank you for tuning in. If you're here live with us or if you're rewatching, feel free to send in more questions after the fact. If you like this or if you have other kind of topics you want us to do, feel free to post about that as well. I'd be happy to do more. Like I say, I miss doing live presentations, so this is as close as I'm going to get now. So thank you for giving me the opportunity to share some of this with you today. And as I said, I'm Dr. Camille Kraus, and I work out of Conceive Health in Waterloo. So feel free to check out the Conceive Health website. There's so much good data in there. I've written a ton of articles and done some videos. Follow us on Instagram, follow me on Instagram. I'm Waterloo Fertility Naturopath. So feel free to get in touch. I'm happy to answer your questions, and I wish you all the best.